everyone. Want to welcome you again to another of our webinars. My name is Ellen Robertson, and I'm the APCP Project Director with the VITAL team. I want to welcome you to our Implementing an Integrated Healthcare Approach webinar. We are very excited you're joining us, and for many of you joining us again today, we are very excited that you're here. This presentation is hosted by VITAL, Alabama Medicaid, Alabama Department of Mental Health, APCP, and Project Freedom. So VITAL, the APCP project falls under VITAL, and APCP looks at substance use disorder and educating and training providers and other healthcare professionals around the different substances and different topics around SUD. VITAL is a partnership between the Alabama state agencies, the University of Alabama School of Social Work. VITAL looks at engagement, collaboration, research, and is committed to improving services, policies, social conditions around mental illness and substance use disorder for those in Alabama. VITAL uses evidence-based practices and aligns principles of research and focuses on evaluation, advocacy, service provision, and community engagement. So a lot of different topics that VITAL covers. So the speakers and the planners for this particular webinar have no financial relationships to disclose. All right, now I know I went through that quickly because we have a great presentation with two great presenters. And so it is my pleasure to introduce today's presenters, Ms. Shana McIntosh and Dr. Lely. Shana McIntosh is the VITAL Director in the School of Social Work at the University of Alabama. She earned a master's degree in counseling and psychology. Shana has more than 10 years of experience as a substance use treatment director, substance use counselor, mental health therapist, and a certified case manager. In her current role as the VITAL Director, my boss, she oversees the implementation of 6 federally funded grants and 1 state-funded grant. She serves as the advisor to the board of the Parent Resource Institute of Drug Education of Tuscaloosa, as well as the Tuscaloosa Mental Health Alliance, and is co-founder of the West Alabama Recovery Coalition. Now, Dr. Lely is a board-certified general psychiatrist, an addiction medicine specialist, and an associate professor in the Department of Psychiatry and Behavioral Neurobiology at UAB. Dr. Lely received her MD from the, I'm going to not pronounce this right, Dr. Lely, I'm sorry, Hubei Medical College, at Wuhan University, and a PhD from the Georgia State University. She was appointed as the medical director for outpatient addiction services at UAB. She has provided services for patients in both inpatient and ambulatory settings. Please type any questions that you have during the presentation into the Q&A box, and I'll ask our presenters those at the end. Shana and Dr. Lely, the mic is yours.
Thank you so much, Ellen. So we're going to just go ahead and get started here. Just to review the objectives of today's presentation, we are going to describe the SBIRT model. We're going to explain best practices for care as it relates to integrated care and the SBIRT model. We're going to discuss with you all the referral process and access to resources in the state to be able to assist with connecting our patients to care. We're actually going to talk about the dynamics of integrated healthcare and those needs of the healthcare system for implementation, as well as the systems that are needed to adopt that tiered service delivery model within this use case of integrated care. So one of the primary issues that we have contributing to the healthcare crisis, and we know that there are a lot of issues out there, but one of the primary issues that we have is scarcity of resources. This does include mental health professionals. Just to kind of give you guys an idea, when we're thinking about our state, the state of Alabama, we've got about 93,000 individuals in the state who maybe use drugs but don't actually receive treatment for it. The number could fluctuate. This is just a guesstimate. And then about 188,000 who actually need treatment for alcohol but may not be receiving it. When we compare that to some of the providers that we actually have here in our state, Psychiatrists, we've got about 7 psychiatrists to every 100,000 residents in the state. We've got about 4.9 million people. I'll be honest, I'm not quite sure what the last census was, but I know when I was last looking, I was about 4.9 million people. So 7 psychiatrists every 100,000, about 14 psychologists to every 100,000, 15 social workers to every 100,000. And we're not even really sure about the psychiatric nurses that are out there. The number was pretty low, so they couldn't really even report on that. And those numbers compared to some of those national averages are actually about half. So nationally, psychiatrists, psychologists, social workers, and psychiatric nurses are more than double than what we have here in our state. So we do know that that contributes pretty significantly to what this healthcare crisis looks like as it relates to some services. Another issue that we know that we have are within our Americans that are using, right? And so when we think about that, 1 in 4 who first smokes, drinks, uses any other drugs before the age of 18 has a substance use problem. If we're able just to be able to get that age up just a little bit, to the age of 21, that statistic becomes much better, and you have 1 in 25 Americans who are first using those elements before the age of 21 that end up having a substance problem. About 1 in 10 people across the nation who actually need treatment are receiving treatment. And we have about 40 million, that's about 1 in 7 ages 12 and older that actually have a substance problem. Now that number is alarming. But let's compare that to some numbers around some chronic health conditions that generally receive pretty significant care when we're thinking about primary health care or even emergency department visits. About 27 million Americans with heart conditions, 26 million with diabetes, and about 19 million with cancer. So when you compare those numbers of these particular healthcare conditions to those of the ones with substance use, I mean, there's no comparison. We have a lot more with substance use issues, and that presents a national issue that Dr. Lely is going to talk about.
Thank you, Shanna. And thank everyone to be here today, especially in Friday afternoon. So hopefully this session can be very engaging with you. So as presented by Shanna, the numbers of patients is very big or huge. And but if let's look at the numbers of addiction psychiatrists or addiction medical providers in the States. And we have only less than 4,000 providers who are certified either in addiction psychiatry or addiction medicine. So compare these 2 different numbers, the numbers of a provider and the number of patients in the United States or in Alabama. There's a huge gap. We have to see how to close the gap, how to provide the adequate care to the patients who need. In order to fill in this gap or to close the gap, Shanna and I are going to talk about the expert and the integrated care. I will turn it back to Shanna.
Thank you. So, you know, there's a lot of reasons why expert could be useful and is very important, and reasons to be able to use it. One of the things when we think about is COVID, right? So as people across the US and the rest of the world are continuing to contend with COVID-19 and its variants, we should be alert to the fact that it is hitting some populations with substance use disorders particularly hard. Because, you know, it attacks the lungs. COVID-19 is an especially serious threat to those who smoke tobacco or marijuana, who vape. People with opioid use disorder and even methamphetamine use disorder are also vulnerable to those drugs, you know, with those drugs with COVID-19 because of the effects on the respiratory and pulmonary health. Additionally, individuals with substance use disorders are more likely to, you know, maybe experience homelessness or incarceration than those in a general population. And we know that those circumstances also pose very unique challenges regarding transmission of COVID-19. We know COVID-19 is posing an immediate and a long-term threat to the health of the country, but especially to those with addiction. So we really have to be alert to that. We know that, you know, drugs do have a wide range of short-term and long-term direct and indirect effects. So these effects often depend on the specific drug or the drug being used, you know, how they're taken, how much is taken, the person's health, you know, number of other factors as well. But, you know, short-term effects, they can range from changes in appetite, wakefulness, heart rate, blood pressure, mood, heart attack, stroke, psychosis, overdose, and even, death. These effects definitely occur maybe just even after one use. Longer term effects can, be heart or lung disease, cancer, mental illness, AIDS and HIV, hepatitis, and others. Long-term effects can also lead to addiction. So when we think about the long-term, drug use and then leading to addiction, which can then, exacerbate those problems. Drug addiction is a brain disorder. And not everyone who uses drugs will become addicted, but for some, drug use can change how certain brain circuits work. They can change how the brain, maybe interferes with how people experience normal pleasures in life, or maybe even such as food and sex, and their ability to control their stress levels, how people experience, decision-making and ability to learn and remember and things like that. And those are significant issues that we have to, really take into consideration in an integrated care model when we're looking at the whole person, not just their physical or their mental, but them as a whole person. When we think about how it can include the affecting of person's nutrition, sleep, decision-making, impulsivity, risk of trauma and violence and injury and communicable diseases, drug use can also affect babies born to women, when they're using while they're pregnant. And, broader negative outcomes can be seen in their education level, their employment, housing, relationships, and criminal justice. So, when you think about SBIRT and why SBIRT, you think about all of those aspects to substance use and how we can impact those by just addressing it. It's also very proven. So, in 1982, the World Health Organization actually began to develop the international screening test for hazardous alcohol use, right? And so they evaluated these patients and how they could be managed in primary healthcare settings. So that project actually produced the audit, which is the alcohol use disorders identification test, which I'll talk about a little bit later. And it's become the most widely used alcohol screening test in the world, in part because of its impressive ability to be able to have some meaningful scientific base, because it's been used a lot, it's been studied, it has a lot of use cases. And then that same study was followed across the world with about 10 nations. And a lot of scientific base was built because of that. So then in 2003, SAMHSA actually initiated the SBIRT program within the US. It had its first cohort of cooperative grants. And one distinguishing feature of SAMHSA within this program was to mandate that they actually include brief treatment. And we'll talk a little bit about that. You'll get to know what these elements mean for SBIRT, and that offer that option as a continuum of SBIRT to be able to offer more services and more access to care because of the lack of access that we had in the States. And so all of this combined really, leads us to be able to have a continued focus on success with cohorts and recipients that led to almost 20 years of research just here in the States from SAMHSA for SBIRT. And then combined with everything that the World Health Organization has put together, it's 40 years of collective international research that's dedicated very specifically to the longevity and the proven effectiveness of SBIRT. So what is SBIRT? Screening, brief intervention, and referral to treatment. Screening. This is where an individual is quickly assessed for their use and their severity of the maybe alcohol, illicit drugs, and prescription drug use. Brief intervention, a 3 to 5 minute motivational awareness raising intervention that is being able to give into risky or problematic substance users, and or brief sessions of treatment can be that brief intervention. And then also referral to treatment, right? This is that specialty care. This is that level of care that wouldn't necessarily be able to be provided within a primary healthcare setting for someone who may have a substance use disorder. So now we're going to go to a poll. So now that you know a little bit about what screening is, can you guys let us know, are you or your agency currently using screenings within your patients for substance use? So we got about 50% of you guys came in on that. And so about 66% of those who responded said yes, 32% said no, and 3% said not sure. So the not sure is perfectly fine. It's okay not to know. Hopefully maybe by the end of this, having a little more knowledge around substance use screening and so forth, you might be able to have a better idea if you are, or you might be so intrigued by it that you go ask if that's occurring. And that's what we would hope, is that you at least raise these conversations. So let's get into more specifically about screening. So, you know, when we think about screening, there's a lot of different tools that you can use, right? So I have given you guys a selection of tools that are all evidence-based and all are validated and free to use without any fees. So these for alcohol are the US Audit C, which is a pre-screen that can be followed up by the US Audit, which is a full screen, and we'll talk about the differences in those. For drugs, the NIDA Quick Screen could be used as a pre-screen, followed by the DAS-10 for a full screen. And for mental health, there's a lot out there, but just some of the ones that are, you know, highly suggested specifically with co-occurring disorders would be the PHQ, which is for depression, and then the GAD, which is for anxiety. And they have a pre-screen and a full screen version of those as well. I think one of the most important things to kind of think about with your screening and the pre-screen and the full screen is it is best practice to use a pre-screen that is universally administered annually to all of your patients, typically during maybe a patient intake process, and then followed up annually with any other annual visit thereafter. The pre-screening is going to help you or your agency be able to rule out patients who present with no to low risk. And then the secondary screening is going to be administered to patients who indicate for an idea that maybe they're participating in some risky substance use behaviors on the pre-screen. The secondary screen is administered also maybe when they present with some clear intoxication or use that's been indicated, or if they've indicated symptoms of depression or suicidal ideations, that PHQ is going to be very helpful. Oftentimes in a medical practice, the PHQ is required. It's generally considered to be an outcome measure, and PHQs are oftentimes asked. So that's a little different. A lot of people are generally asking that. I do want you to be aware, though, although these tools that I have listed here are considered to be the state standard, and the tools that are considered to be accepted by the state, there are some other tools that are highly accepted by the state and used as well. The UNCOPE, the opioid risk tool, the fetal alcohol screening test, the Michigan alcohol screening test, the Columbia suicide severity rating scale, the ASSIST, the CAGE, the CRAFT, the NIAAA alcohol screener, the PCL for PTSD, and all of those, again, validated evidence-based tools that can be used for free. So let's talk a little bit more in depth about some of the screening tools that I had mentioned that we recommend and support. The US Audit. So the US Audit C, this is used to determine risk, right? And that's the pre-screen, where the full audit is used to determine severity. And so you're going to ask these questions of your patient. They can be self-report, they can be questionnaire, they can be interview. There's multiple ways you can do that. And then you're going to score them. And so these scores are going to come across the top there for you to be able to see. The US Audit C has the scores of 0 to 6, where the US Audit has the scores of 0 to 4. So you're going to add up that pre-screen for each one of those responses. And if a female or a male age 65 or less has a 0 to 6 score, or if a male has a 0 to 7 score, you're going to provide some positive reinforcement. You're going to not really do any further assessments. It's generally not recommended to go on and do the audit at that point, because they're practicing either within low risk drinking limits or they're abstinent of alcohol. If the scores for a male or a over 65 or a female are 7 or above, or the male age 64 or below has a score of 8 or above, you do want to provide the rest of that US Audit. And then at that point, that scoring range is 0 to 4, and you would add up that, add the two scores together to get a full score. And then there is a determination on their risk level from that. For females, at that point, it's 15 and above, you would get a brief intervention. For a male, it's going to be, 7 to 15, you're going to get a brief intervention. For males, it's 8 to 15. And then you're going to get a brief treatment if their score is 16 to 24. And then you're going to provide a referral to treatment if the score is 25 or more. I'm going to go over those scores again with you guys. I have another slide that'll be able to present those scores with the intervention and how that, the risk level, and how that all kind of coincides. So then let's talk about the NIDA Quick Screen, which is for substance use. Now, the originating NIDA Quick Screen that can be found out there actually states in the past year, how often have you used illegal drugs or prescription drugs for non-medical reasons? We started using this within the state of Alabama, and we realized that there was some complications with this particular question, that individuals were either not reading it all the way through, or they were misunderstanding it, or they didn't quite comprehend what it was trying to get to. So we have adapted that to the 3 questions that you see below, which really gets at the heart of what that NIDA Quick Screen was asking. Do you misuse or overuse your own prescription medications? Do you take other people's prescription medications? And how often have you used any street drugs, right? So marijuana, crack cocaine, crystal meth, heroin, any street drugs, because essentially that gets to your illegal drugs that were up there. We noticed that illegal also presented some challenges with individuals not wanting to self-report that use because it's illegal. So therefore they thought they might get in trouble for it, especially around marijuana. And then of course we get to the prescription drug use for non-medical reasons, which would be misusing or overusing your own medication or the use of someone else's medication, whether it's purchased or provided to you. So on this pre-screen, anything other than never, if they respond positively once or twice monthly, any of that to any of these questions, you're actually going to actually provide the DAST. You want to be able to provide that next level of screening. If there's never on all the questions, no further assessments actually required at that point. So it's a very quick way to be able to determine risk. If you do need to ask the DAST, you're going to actually ask the last 9 questions of the DAST, because the first question is just, do you use drugs? And so you'll ask the last 9. These are actually scored on a 1 or a 0 level. You do want to be careful because there's 2 versions of the DAST out there, where that second question that you see on my screen, are you able to stop using drugs when you want to? There's a version out there that says, are you unable to start using? And on that one, the score is actually transposed. So a yes is a 0 and a 1, a no is a 1. So you do want to be careful and make sure that you're looking at the right version of that. However, 0 on the DAST is no risk. 1 to 2 is going to give a mild risk. 3 to 5 is going to be a moderate risk. And then 6 to 10 is going to present a severe risk for substance use. And again, same thing here. Your pre-screen was really being able to indicate your risk, where this is indicating some severity. PHQ, this is more widely known than some of the other screening tools. Each response from this, from the PHQ-9 as a whole, has a score ranging from 0 to 3, okay? And then the first 2 questions, along with that third question, is what we call the PHQ-3 that's used as a screener. It's going to be able to indicate some risk around depressive symptoms, as well as asking that very last question around suicide, because oftentimes an individual can have some suicidal thoughts or ideations and maybe not be in that depressed state. So you do want to be able to ask that. And so from here, if there's any indication of the depressive symptoms or suicide, you would want to go on and be able to ask that next level of questions. I will say that the scores on this risk level are a little bit more obscure. Generally, a 0 to 4 is going to be low to no risk, and a 5 or above is going to be a mild risk monitor, and you might want to repeat that PHQ. You can find various scoring stratification among the PHQ out there. We do suggest that the provider really determine what steps need to be taken based on the responses of the patient, right? However, a score of 10 or more can actually indicate a clinically significant problem, and therefore likely trigger a referral to a mental health service. The provider may choose to provide those services within their facility if you're able to, or you might want to refer them to an external service, but that's just kind of a general rule of thumb. And then there's the GAD-7, which again is the general anxiety disorder screening tool. The GAD-2 are the first 2 questions. If they get a 3 or above on those questions, you'll actually move on to the full GAD. Probable anxiety diagnosis is generally around an 8+. But again, you want to be able to follow whatever protocols are decided upon by the provider within the agency. Dr. Lely, before I move on to kind of what all of this means, do you want to talk anything about these screening tools?
I think we are fine. And I'm very curious when I was listening to you, how many of these validated tools has been used by the providers here?
How many of those different tools? So as far as right now, the standardization are the Audit C and the NIDA adapted version and the PHQ-3 for the pre-screen. That is the general use of that, followed up by the Audit, the DAST, and the full PHQ if needed. The GAD-7 is used very little among the providers. It's generally the PHQ because it's already included in their practice structure. It's not something that was added. So that's generally the tools that are being used and much more widely accepted for the practices that we're working with.
And also, I think from my experience to practice at UAB, our EMR actually has built like a GAD-7, PHQ-9 to DAST and assist in the EMR itself. So as long as you open patient chart, you are able to go ahead and do the screen and document the numbers for each skills. So very
Correct.
convenient. It can be built into your EMR.
And that's correct. And that's one of the reasons why we chose those for the state of Alabama, because they are more widely accepted, and most of our electronic health records or medical records that we have familiarity with in the state of Alabama actually already have those incorporated. So, you know, I talked a lot about all of these scores. It can seem overwhelming to think about all these scores equaling all these things. So we created a table that makes it pretty simplistic that will show you the audit score, the DAST score, and then where this risk level falls. So you'll see those scores among the audit and the DAST, and then low, mild, moderate, and severe. And then below that, creating a chart where if they're low, mild, moderate, or severe, what type of service do you offer? Do you reinforce the use case that they're in? Do you provide a brief intervention? Do you provide that brief treatment, or do you provide that referral to treatment? So it may have seemed much more convoluted when I was kind of speaking through it, but this chart definitely helps kind of bring it closer to home, so it's a little easier to follow. So then you think to yourself, oh my goodness, if I start asking all of these questions to all of these patients universally, I'm never going to have time to do anything else. That's really not the case. Oftentimes, it's a very short process. The screen, especially if you allow them to do those pre-screen self-report in the lobby while they're waiting on you with a little bit of wait time that they have anyway. Once you actually make it back to their exam room, the process in of itself could take anywhere from 5 to 20 minutes total, and 20 is like a very significant case where there's some pretty significant issues that you're going to have to walk through. However, you're really not going to have that happen with too many patients. National averages are showing about 78% to 85% of individuals are actually falling out to that low to no risk. So when you're asking that pre-screen, there's no follow-up questions that need to be asked. You're going to provide some feedback to them and reinforce their continued behavior. Providing some educational materials along the way, because maybe they didn't tell you the truth, right? We know all of our patients don't tell us the truth all the time. So at that point in time, you want to be able to provide them with some educational materials. So if they aren't telling the truth, they at least have that information on hand based on their use that they did report. You're going to have about 9% of your population that's going to fall into that risky use, where you're going to be able to provide a brief intervention. And then about 8% that might fall into your brief treatment, where you're going to maybe either provide brief treatment on site or refer them to brief treatment, and then very small 5% that will actually need a referral to treatment. Remembering that SBIRT in and of itself is not meant to actually address those who are already dependent and having issues with substances, but to be able to identify and intervene with those who are at risk, so we can hopefully be able to curb that continuing circumstances for them. So I'm just going to go over quickly a brief intervention, brief treatment, and referral to treatment. I'm not actually going to teach you how to do any of these things, but just so you'll have an idea of what they are. So brief intervention is a collaborative conversation that enhances the patient's motivation to change their use of alcohol and/or drugs. It's really to be able to lower that risk of alcohol or drug-related problems as it relates to not only their use, but also their medical condition or any other factors. The brief intervention could consist of offering advice, education about substance use, focus on eliciting their own reasons to change. The practitioner guides the patient to develop his or her own plan for change. This is not the provider's plan, this is the patient's plan. And the BI is going to focus on whatever small steps that the patient is willing to make. Brief interventions can be tailored for a variance in population or setting. So it can be anywhere from primary care through EDs. It can be anywhere from pregnant women through general, through geriatric, through specialty care. So brief intervention in primary care can generally range from about 5 minutes to even several follow-up conversations. It can be highly structured or less structured, especially when time is limited. Many of the tools that are used in a brief intervention are actually based on motivational interviewing concepts. And so this session is not meant to actually, teach you that brief intervention, but some of the most important elements to accomplish with your time together with a patient in a brief intervention would be reviewing the results and offering feedback, maybe compared to some of those norms for use, assessing the patient's view of their substance use, asking about goals, and if nothing is really suggested or offered, maybe providing some to help with their awareness, provide educational materials or any links to any online information that you might be able to have access to, and then set that follow-up appointment, or at least make a plan to discuss with them in the future. And if needed, make a referral. That's really what the brief intervention is about. So brief treatment is a little bit higher level of care. They may need more support to actually change their behaviors and their use. This would generally occur with a qualified clinician to be able to develop awareness or any required skills like rebuilding skills, developing support and things like that. Brief treatment is going to differ from a brief intervention and even some other treatments, because it's a structured counseling method that helps patients identify maybe their personal beliefs in substance use and how these beliefs influence their feelings and behaviors, which are similar to some of those other treatments, but it's going to be very brief and completed using various different treatment modalities. Maybe it's ICT, integrated change therapy. Maybe the clinician might be using CBT, cognitive behavioral therapy, or MET, motivational enhancement therapy. Those are generally the most recommended, but you can use a lot of different modalities, but it is still very brief. It can be considered an outpatient level of care if needed, although one of the underlying principles of SBIRT is actually to reduce barriers to treatment and actually provide on-site services. If there's not a qualified clinician on site, patients seeking brief treatment or needing brief treatment could be referred to a qualified clinician outside, which may end up being an outpatient level of care. And then there's referral to treatment. So this is when the screening is going to indicate that severe risk. It's specialized treatment that's provided to really those that are identified as needing more extensive treatment that can be offered by the SBIRT program or within a primary healthcare setting. I will say the effectiveness of a referral to specialty care is definitely a strong measure of the SBIRT success itself, and is going to involve a proactive and collaborative effort between your SBIRT staff and providers within the facility where you're doing SBIRT, and then community treatment providers as well. You really want a strong relationship. Developing and sustaining those relationships is key to ensure a successful warm handoff, right? So, we want to be able to think about warm handoff and those best practices. Engagement and rapport is huge with a warm handoff. We do not want to hand someone a piece of paper with a phone number and an address and tell them to follow up. You wouldn't do that if a patient needed an MRI. You wouldn't do that if a patient needed a consult with a specialty doctor. You would handle that internally for them. So we want to do the same thing with these patients. We want to make sure that we're reinforcing a team concept. We want to make sure that we're allowing for an immediate start of treatment if possible. We want to make sure that we can connect them with either the individual on-site or off-site that's going to be able to provide that level of service to them. And we want to make sure that they fully understand what that's going to look and feel like. Best case scenario is a face-to-face brief introduction that ends with an appointment. That might not be possible. For most of us, it's not. Integrated care, which Dr. Lely is going to get into here in just a second, tends to not be as common where you can do everything all in one place. However, have that backup plan. A warm referral process can also include, maybe direct contact between the provider via phone or email, where the clinical information is exchanged immediately, and you as the on-site provider are able to connect that person with their service and not expect them to connect themselves, where still at the end of the process, the appointment is made. Accountability is really essential when it comes to the referral process. Practices need to really be able to define those expectations for the community providers they're working with, and make sure that they're actually following up, because you're all on the same team, and you really want your patient to feel like that. After the handoff, you do want to close the loop. You want to make sure that your EHR or EMR is fully updated and documented for what's happened. You want to have case conferencing, and you want to be able to confirm that appointment attendance with your community provider as well. So for that, it may require a release of information. If the patient's unwilling to do a referral, do plan to follow up with them. And that follow-up doesn't have to be in person. That follow-up can actually be on the phone if necessary. So I've talked about this big, huge process, and let's just kind of lay it out for you. You can see from the top, we pre-screen, we maybe provide some feedback, maybe we do a couple of other screens. From there, it's pretty simple. Do they need a mental health referral? Do they need brief intervention? Do they need brief treatment? Do they need referral to treatment? From there, how many services are you going to provide? What's that follow-up and discharge going to look like? So it looks pretty simple when you look at it like this. I know it sounds like it's a little more overwhelming, but it can be pretty straightforward to put this into a clinical practice, which we'll talk about a little bit in a bit. So just in summary, SBIRT, it's brief. The initial screening is accomplished, pretty quickly, usually 5 to 10 minutes, and the intervention and treatment components indicated by that screening are completed in significantly less time than any traditional substance use care that's out there. The screening is universal. Patients, clients, students, other target populations are all screened as a part of the standard intake process. One or more specific behaviors are targeted. The screening tool addresses a very specific behavioral characteristic deemed to be problematic or preconditional to a condition to substance use dependence or any other diagnosis. The service occurs in a health or non-substance use treatment setting. This may be an emergency department, primary care physician's office, school, etc. It's comprehensive. The program includes a seamless transition between brief universal screening, a brief intervention or brief treatment, and then a referral to specialty substance abuse care. And then strong research or substantial experiential evidence supports this model. At a minimum, programmatic outcomes demonstrate the successful approach of SBIRT among our US population and in Alabama. So poll question number 2. Are you or your agency currently practicing integrated care? All right, Dr. Lily.
Thank you, Shanna. So the result is pretty interesting. And actually, I'm not surprised to see the results like this. But I thank you so much for telling me what you are doing in your own practice. Next slide, please. Is not new to each of us, but what it really means, I think for the SAMHSA itself, it defines as the systematic coordination of general and behavioral health, integrating mental health, substance use, and primary care services, produce the best outcomes and proves the most efficient, effective approach to caring for people with multiple healthcare needs. So in my understanding, I probably very kind of a layperson language, which is one-stop shop for patients who have more than one need, from primary care needs to psychiatric illness to substance use. So try to combine them together to make it very affordable. In the meantime, to be very convenient to our patients. Next slide, please. Okay, so for the integrated care, it's very broad. It's not only one model or one thing at all. Can be divided into 6 different levels. So I'm going to kind of review 6 levels with you, and you can think which level you are doing, or are you doing all the different levels, give different situations. So look at level 1 and 2. They are similar, but has a slight difference. And level 1 and 2 more focus on referral per se. Level 1 is each providers practice themselves. There's no much interaction, no much communication, very minimal. But level 2 has some interaction and communication, but it's still very limited. For example, if I have patients who have diabetes, I prefer not to manage their diabetes. I want to refer to another provider at UAB. I may just type, hey, Dr. A, I have a patient, blah, blah, blah. So only this is what I'm doing in the level 2. But if I move on to the level 3, 4, or even 5 and 6, I will do much more than what I'm going to do in level 2. So level 3 and 4 are more talk about a co-location care. Because at level 3, we offer us at UAB to practice, but you and I have different supportive staff. We have different scheduling. We have different offices, and we have shared the patients. And I know you are her primary care doctor, and you know I'm her psychiatrist and addiction care doctor. But we don't really interact with each other, except we always look at each other's notes to see what you have done for these particular patients. So the communication happens more using EMR level. But if we move to level 4, I will drag you to the care and say, hey, Dr. A, can we have a meeting today to discuss the patient A? And I have so many concerns from A to Z. And so this case is more coherent, and we may share the same like scheduling service, and we have the same treatment meetings, but it's still in the communication level. There's no much in like a in-person meetings, or we have treatment meetings. Usually we have not reached there, but on level 5 and level 6, which as we share so many things. We share the same facility, same office, and the same administrative staff, and the same scheduling, same patients, of course. And at level 5, we do have treatment meetings from time to time, but not consistent. And patients may sometimes have to come to the office in a different time to be seen by either me or different providers. So it's still not a one-stop care yet. So level 6 is the ideal way. And everything happens in the same time, same location. Patient will be seen by the nurse or case manager, social worker, counselors, providers at the same time. So they only need to come one time for all their needs, which is very convenient. Next slide, please. So why do we need the integrated care? Of course, we want our desire as provider is to reduce the medical cost, but improve patient experience, also improve our own experience with the patients, right? And patients always have more than one illness. And for example, my patients with schizophrenia could have diabetes, hypertension, or even stroke, because their lifestyle is so sedentary. And also they take antipsychotic medications, which have a higher risk to make them have metabolic syndrome. So I do need to collaborate with the primary care or some other specialist. So that's why integrated care is so important for us to provide a better care or convenient, affordable care to our patients. Next slide, please. So that's really the kind of a design of healthcare in the United States. Primary care physicians are always on the front line to see all the patients. And when our patients have any issues, they will think of primary care first. They may not think of a psychiatrist or addiction doctor first. They always, I'm going to see my primary care physicians to see how they can help me. So if primary care can start to practice or kind of continue to practice expert or integrated care, it really helps a lot. And also, like Shannon talked about, there are so many validated tools. They are free, very easy to use, and built in EMR. You just need to click, and then spend 1 or 2 minutes with your patients. Then you will have the score, and then you can stratify into from low, in the middle, and high risk, and then you know what to do next. That can increase the patient's, improve patient care. In the meantime, make your practice itself to be very meaningful, to be more comprehensive. Next slide, please. So there are many components or essential elements to make sure the integrated care itself to be successful. Per se, you are very motivated or you are interested in to using these skills or tools in your practice. And then you communicate with your patients what you are doing, what other physicians are doing in the same patients, and also educate the patients what we are doing and make sure patients do understand what we are doing for them, from diagnosis, assessment, treatment plan, follow up, and all these components we should share with the patients, and I want to make sure patients do understand what we are doing there. So patients' involvement, engagement is really key to make sure the care itself is successful. Of course, we cannot function without the case managers, coordinators, counselors. They are also key players in the team. Next slide. And when patients know more of their treatment plan, I'm pretty sure they are more compliant and they take a medication more often than supposed to. And also, if patients can access to their own medical records in the EMR, and patients can really use that as reference and always can be compliant with that, that will another big plus. Next slide, please. So in terms of outcomes of integrated care, I'm pretty sure each of you already know it, and there's not enough evidence or research has clearly indicated that outcomes for integrated care, especially in the level 5 and 6, is very good. From patient perspective, they feel better. They have a more positive experience in their care. They are more compliant, and they have much better outcomes in terms of their medical illness, psychiatric illness, and the sobriety rate. From a physician or provider perspective, we feel like our work is so rewarding and have a better positive experience with our own patients. We are proud of our patients' success in their care. In the meantime, also reduce our own burnout and fatigue at work. So integrated care has been approved to reduce medical cost, and hopefully our experience or our data for integrated care can provide us some evidence for the policy changes, make the policy to be more user friendly for our patients. Next slide, please. Okay, so if any of you have any questions, we do have time to for the Q&A at the end of the session. And otherwise, I will take it back to Shanna, and she will continue to introduce the billing and other related issues.
Thank you so much. So we're going to follow up just kind of quickly with billing, a little bit of implications for implementation, as well as some referral that we want to leave you guys with. So billing, okay, all this expert stuff, all this integrated care stuff, it sounds incredible, right? But is it billable? Because that's what oftentimes we want to know. So, currently the only active expert billing codes in Alabama can actually be used with the maternity population through Alabama Medicaid. To use these Alabama Medicaid codes, a provider must complete the expert certification course, which you can contact Vital if you're an Medicaid provider for pregnant or those becoming pregnant women to get that done. And then you do the certification, you get it turned on, and those access codes are available for you. So, the intent of these expert codes under the maternity program are actually to provide services for substance use to include alcohol and drug use only. Smoking cessation is actually covered under care coordination. So there's some payer codes that you see down there for Medicaid that I have, and those H0049 and H0050. It's for the screening. It's for an episode. and it's actually 1 per pregnancy on the H0049. It's actually 1 per day, 2 per pregnancy on the 0050. And that's your brief intervention for, the 15 minutes following up from that. So that's your alcohol screening and brief intervention on that one. I would suggest that if you want any more information about the Medicaid billing codes, is that you do reach out and look at your billing manual, chapter 40 for those. That's where you're going to find the SBIRT information. The others, although there's some commercial insurance and Medicare codes, they are not widely used or accepted in the state. However, I do want to provide you that some health plans will now pay for alcohol and substance use screening with validated instruments. Remember that. And all instruments that we've introduced in this guide are actually validated. So anything that we've provided for you in this presentation is validated. So they're doing those for validated instruments and intervention services using preventative codes or evaluation and management codes. So that's that E&M code, or even the health behavior assessment and intervention codes. Those are your HBAI codes. So as SBIRT services billing do vary by payer for sure. You do want to consult with your insurance payer source for appropriate billing codes to make sure that they're going to fall within. In addition to that, you're going to see on here that there are some pretty specific provider types that have to be present or a part of these sessions for these to be considered billable under some of our payer sources in the state. If you do want some more information about billing, please feel free to reach out to us. However, the process is so limited in the requirement of time, and the outcome for your patients is so great that being able to implement these into your normal practice flow does have some advantage. So let's talk about referral sources real quick. I'm going to quickly show you guys this website, SAMHSA's website for the treatment locator. So you can actually look at this website when you want to look at all types of treatment, when you want to try to find a buprenorphine provider, when you want to try to find an OTP, which is considered a methadone providers, or any serious mental illness, as well as DEA verification. So if we have any pharmacists on the presentation today, you can actually go in and look up DEA verification to make sure that these providers should be providing these services. So the website looks like this. Your treatment services locator, you would click in it, and I'm not going to show you all of it. It'll bring you up to this. You can put a city or a zip code in to be able to find some treatment. It's really, really easy to do. You can come back out. Same thing with the behavioral health services locator. The buprenorphine is a little bit different. You'll actually go through and you'll find your state, and then you can narrow down from there on your state. Depending on what you put in, it will actually give you a full listing of those. And then we have the OTP, which is also a little bit different. It's just going to go ahead and give you the state. And then from there, you're going to get the entire selection of OTPs. If you want to map it, all the information is there, but that's accessible for you. And then lastly, we have the DEA, and that is going to be over here on the left, where you would be able to, well, the DEA one, where did it go? They have moved it. I'm so sorry. They have moved it. It was right over here on the left, and there was a DEA locator, but you can search for that and be able to find it. You can actually type in the DEA number, and it will let you know if that individual is able to provide services. You also have some state services. I would suggest going to the ADMH website. When you do, go to Find Help, and there's a provider directory there. You can type in the type of service, whether it's substance use, mental health, or even prevention, mental disability services. You can type in you can actually select from a drop-down menu the county, and it'll give you all the providers that are available. You can also look up peer services on the ADMH website as well. Peer services are provided by those with lived experience in recovery, and will be able to provide anything from just talking, if someone needs to talk something out, all the way to help get them into treatment as well. It's a great resource, and I'm going to give you a phone number for this. I highly suggest anyone write this number down. It is a 24/7 helpline for ROSS, which is the Recovery or Organization of Support Services for our state. Any time of day, any day of the year, you can call this phone number, and a recovery support specialist will actually answer the phone and be able to help. They will help a professional. They will help a family member. They will help a person that is in need. So if it's just getting information, if it's talking to someone, if it's helping someone through a process as it relates to any of their risky behaviors or use, This is a really great resource. And again, everyone here has lived experience and has a lot of experience with our state system of care to be able to get someone connected. Write this number down, keep it. Lastly, I would suggest you check out the VITAL website. We have a find treatment option under our resources. It will get you connected to the resources I've shared. It will also get you connected to support groups and be able to find local chapters for support groups that are out there. So very quickly, I'm going to review some necessary conditions for implementation. So there are some factors that might influence your ability to be able to implement integrated care, right? Maybe it's the organization's visions for care. Maybe it's their capacity to change. Maybe it's funding and understanding the cost of care. Maybe it's infrastructure with staff capacity, you know, maybe their capacity to capture the patients, to manage, to share the information. Both provider and state levels can be an issue for this. Maybe it's the provider network. Who does what? Who gets along with who? Where can we refer? What are we close to logistically? So those organizational components that are impacted by adoption of integrated healthcare models, such as SBIRT, do need to be considered. You want to be able to look at staffing. You want to be able to look at your partnerships and contracting. You know, who are you actually going to partner with? Your finances. Do you have those available service codes that you want to build? If not, do you have something built in that's going to be able to work for you? Your clinical practice, what does your workflow look like? Will it be revised? Can you put these things, you know, into your current patterns with those staffing pieces that kind of touch your patients at different level? Your HIT and your data, you know, that, you know, health information technology is really important. You had Dr. Lilly talking about the ease of integrating this into their EMR. Most EMRs are like that, but you really want to look into that. You want to be able to minimize any error in gathering and collecting the data, as well as being able to process it, making sure that it's easy to find once you do. And then you always want to make sure that you have a quality assurance and improvement plan that's put in place. You want to be able to look and evaluate continuously, observing the services that are being offered, continuous training to your staff to make sure that things are happening, continuous data pools to kind of see where you are with all of that. You just want to be able to think about some of those things. And then lastly, this working conditions. Oftentimes with a practice at that system level, you can't stop what you're doing to build something like this. You have a practice that's going, you have patients that you're seeing, so you're going to be building that plane really while it's flying, and that's okay. You want to be able to kind of put in some, you know, plan, do, study, act kind of stuff, right? You want to be able to look at that over time and see what's working. You want to make sure that you separate, you know, different lines of controls and management when you're doing that, you know, looking at workforce readiness and training at that system level. And then there might even be some team level conditions. You know, do you have resistance to change among some of your staff members? Are there any power struggles around who feels like they want to do what, or who feels like they don't want to do what, right? Because maybe they already have a lot going on. Are you going to shift from that individual to that team philosophy where you do this versus we do this? That professional culture around integrated care, and then just those inequities and that status around, you know, perceiving, are those perceived or are those real? Are those inequities something that we can actually look at, or are those something that we need to address? So those are just some working list of conditions. So we have a last poll, and then I'm going to turn it back over to wrap up with Ellen. So this will just be a quick poll. Are you interested in learning more about SBIRT implementation and integrated care?
And while we're waiting for people to answer, I do have more ask a question. Are these tools that you've gone over today free for use for everyone?
Yes, they are. And you can actually locate these tools on the VITAL website. If you're interested, you can actually reach out to me. My website, my email is going to be up in a minute, and we have an SBIRT toolkit that's a full integrative SBIRT toolkit for implementation. And then we would be really happy to come out and actually be able to provide some technical assistance if you want. And there are our emails for any additional questions that you may have. I know we are almost out of time and you have a few other slides to go through. Were there any other immediate questions, Ellen, that we needed to get to, or do we want to let us look at those and get back?
I have one more. We usually run about 5 minutes over, so I'm going to ask this one more. Find it. Oh, here. Why are the screening tools that y'all went over today preferred over the medical history and social history?
So that's a really good question. Oftentimes, and I'm going to let Dr. Lely speak to this too, the medical history and their social history are generally very generic questions that are meant to be asked for an outcome and a requirement for a payer source, and those are integrated into that history. They don't actually provide you any real level of risk or severity. However, if you do have some questions that are actually getting to some specific details around their use for drugs, alcohol, tobacco, other social things, and you want to use that as your risk, and then use these other validated tools for your severity, that has happened in practices and definitely can work. So Dr. Lely?
I think you have touched all the points. And what I'm going to add on is for the medical history and the social history. For many histories, if you don't ask a patient specifically, they do not tell you. Per se, for the social history, like alcohol use disorder, if you don't really quantify how often do you drink, how much do you drink every single time when you drink. So if you don't go that details, the patients just say, yeah, I drink occasionally or socially. So social drink to us maybe less than 2 or 3 drinks per week. But a social drink to some patients maybe more than 20 drinks per week. So all the tools Shanna discussed are kind of quantifying tools, exactly how much, how often. So the numbers are very important for us. There's a sort of like a normal range. There's sort of like an abnormal range. So there's a kind of difference between the tools versus like a social history or medical history.
We want to thank you very much for participating in the webinar, and we hope to see you. And you can also visit the Vital Alabama website and follow us on social media. And just as a point, we do have a Facebook Live event coming up. You will see me again, but what you didn't know about supporting patients in recovery. We'll have Jennifer Smith, the SBIRT project director, and Dr. Mark Westfall, who some of you may have heard. He will be presenting, well, it'll be more of a panel discussion. So we hope to see you there, and you can follow us on Facebook. All right. Well, thank you all very much, and we will see y'all next time. Bye.